Greetings, everyone, and welcome to this year's See Arthritis event. And I'm joined today by Dr. Karine Toupin April. She's an associate professor in the School of Rehabilitation Sciences at the University of Ottawa, and she's cross-appointed with the Department of Pediatrics and is affiliated with the Children's Hospital of Eastern Ontario Research Institute. Dr. Toupin April, welcome.
Thank you. Thank you for having me.
Our focus today is going to be on a workshop that you're leading in Winnipeg. And its title is interesting, and it'll be interesting, I think, for our audience too. And that is Clinical Practice Guidelines and Interprofessional Shared Decision Making, a Journey Towards Health Equity. So our audience has heard us talk a lot about shared decision making. It's the key element of a model of care for inflammatory arthritis, as an example. And one of our focuses in the public policy area is on health equity. But our audience hasn't heard us use those two terms together very often. So we're really interested to hear about this integration. And I guess to start off, if you're talking about recommendations for clinical practice guidelines, that obviously means that there's been some research done and you've found some gaps that you're hoping to solve through these reforms through these practice guidelines. So tell us, I guess, set it up for us. What is the issue? What is the challenge or gap in care that you're addressing with these clinical practice guidelines?
Okay, so I think it's a very complex topic. I think our workshop has a lot of keywords in it: clinical practice guidelines, shared decision making, interprofessional, and health equity. And I think there's many gaps regarding all of these aspects in care, right? So I think we think clinical practice guidelines, we think sometimes, it's not supposed to be like that, but it's kind of used sometimes as a recipe. We're going to follow the clinical practice guidelines and we're going to treat people, and it tells us how to treat people exactly, right? Which is not really the case, because each person is individual, right? Each patient has their own values, their own preferences, their own set of circumstances. And so I think that's already kind of a problem a bit with our notion of clinical practice guidelines. So I think that has to be very personalized to each person. And also, so when we think about, health equity, I think there's a lot of reasons that, care is often not equitable. It's not like exactly the same for each individual. Each individual has their own set of circumstances, and it may be difficult to access care, access rheumatologists, access physiotherapists, occupational therapists. It might be difficult to pay for certain medications. It may be difficult to pay for certain non-pharmacological treatments. And it may be difficult to even just understand what the physician is telling us or what the occupational therapist is telling us, right? So there's a lot of, I think, differences between, patients in how they understand, for example, the information that is given to them. So all of these are kind of, can be problematic. When we think about interprofessional, that's a whole other aspect, because, care should be interprofessional. So care of rheumatoid arthritis, of osteoarthritis, it should be with a few different healthcare providers working together for a specific patient. And I think that's not always the case, because it's very hard to access many of the healthcare providers. And then you have shared decision making, which I see personally as a patient and as a researcher and as someone trained as an occupational therapist. I see shared decision making as really giving patients all the information about the different treatment options, as well as evidence-based information, right? Like, what does the literature say on this medication or on that physiotherapy treatment? And also really taking into account each person's values and preferences. So I see shared decision-making as one of the optimal ways to make decisions, and I think it's kind of widely accepted. And it is shared with healthcare providers, but it's not healthcare providers who should tell a patient, you're going to follow this treatment because this is what's best for you. Instead, they're going to say, well, there are different options that are possible for you. And this is the evidence that we have on how they work, how safe they are, how are they taken, right? Because you have medication that are by injection, by infusion, by pills. So all of, twice a day, once a week. So all of this, the patient has to really think of what is the most important to me? What can I do practically in my daily life? What do I prefer? And then that really informs the decision that is made. So to me, shared decision-making, putting shared decision-making in the mix of all these complex, aspects of care, it really means that it's personalized to each person, and it can really help potentially, to diminish some of the barriers that people have in making decisions, right? So shared decision-making can really help people to be engaged in their care, to truly make the best decision possible, to make a decision that is informed by the evidence, but also informed by what is truly important to me. So I won't be told you're going to use this treatment, and then the next day I go on Google and find other information, and then I'm like, not sure if I want to follow the treatment. All of a sudden I'm like, well, I'm afraid of that side effect, and I'm not sure I was very clear on this, so I'm not going to take it, right? So I think it has a way, it can really help to empower people, and, helping people to make the best decision for themselves could mean that, depending on my characteristic as a patient, I will make sure that really the decision is the best for me. So, it doesn't matter my level of education, my ethnicity, whatever, all of this will take into account.
It resonates for our audience because, as you may be aware, ACE over the last 4 or 5 years has been conducting national surveys on hot topics in arthritis in Canada. And we've looked specifically at health inequities. We've looked at health literacy. We've looked at the use of virtual care. We've looked at reimbursement coverage for arthritis medications. And consistently with all of these national surveys, we found a disparity between a white or non-BIPOC patient population, quite simply. And so I think, we talk sometimes in these ideal scenarios where when we're trying to educate and empower our patient members and subscribers, we often describe it in terms of their relationship and role with their healthcare team in the context of shared decision making. Is they are the quarterbacks. They should be the captains of the team. It's one thing to tell, a person that looks like me that. It's quite another to tell a newly arrived immigrant or a BIPOC patient, Black, Indigenous person of color, who has some very serious, very real cultural barriers to assuming that role, to achieving, I think, what you're describing. So how do these clinical guidelines help address that?
So I think there's many different clinical practice guidelines, and then from clinical practice guidelines we can develop tools to help to help facilitate shared decision making. So to give some examples, I think Glenn Hazelwood and his team, they have the RA guidelines, and so they develop a patient decision aid that can be used to really help people, be engaged in the decision making process. Cheryl Barnaby has adapted that patient decision aid for Indigenous patients. And so I find, so you have these tools that can help, I think, to make it more concrete and help to do shared decision making. The one thing also with shared decision making is it doesn't mean necessarily that the patient is, taking the lead and being in charge of everything. I think it depends, right? One of the elements is we should ask patients how they want to be engaged in making the decision, how they feel comfortable, So how do you want to be engaged in the decision-making process? What kind of information you want? Do you want it to, there's patient decision aids, for example, that are low literacy patient decision aids that I have used, So there's one for rheumatoid arthritis, created in the US. But I mean, I think it's important that these options are there. Like, how do you want to be engaged? The rheumatologists or healthcare providers can provide some information. How do they want information? So I think it's important to really personalize, right? So I think it's not the goal to say to patients, you have to be in charge of everything and you have to decide everything. And it puts a lot of pressure on people, right? So I think each person should decide how they're going to make the decision, what information they want, in what format. And there's a lot of different tools that can help to really simplify the information, for example, right? So I prefer personally to have like the different treatments for RA. So I would like to see the different, for example, medication, one next to another with like how they work, and what are the things I have to be careful about for each of them. And then I can discuss with my rheumatologist. And maybe I want more information. Maybe I want to go see one of the scientific papers, but maybe someone else doesn't want to see that. They want to see something else. So I think it's really important that it's personalized, I think. And I think for Indigenous patients, for example, Cheryl Barnaby has done a lot of research on that. I mean, I think she showed that like you could use a patient decision aid with decision coaching, which is the help of someone who can help to make the best decision for the person. So not telling them you're going to use this, but telling them, hey, what's important to you? What do you want? And then we'll try to figure it out. And so that's very interesting in itself, right? So it doesn't mean there's one size fits all. I think there's many different ways to do it, but people have to kind of. I think there's a lot of research being done, but I think we shouldn't like force people to be into a specific way of making decisions, right? We should ask them what they want.
So we're really encouraged that the CRA as a body and individual rheumatology leaders like yourself are having this conversation. So 10 years ago, systemic biases or language barriers, socioeconomic challenges, geographic disparities, they weren't being discussed at the level that they are today. So I think that's really, really encouraging. This work that you're doing is fantastic. One of the questions that I know probably will come up in Winnipeg is, how are you going to measure progress? What, are there performance indicators? I know that's a popular term that researchers like to use, but in lay terms, what how can it be measured if our end goal is promoting health equity through these guidelines and this shared decision making approach? How can we measure that we're on this path to improvement?
Wow. So I'm not sure I'm the best person to answer this. Like, if you look at the whole health equity lens, I think, there's a lot of people that we work with that are amazing. I think so. I think one of the things, if I look at it from the decision-making perspective, meaning, often, so we've built like patient decision aids, like we have one for juvenile arthritis that we're working on for pain management. So we're going to test these tools and we're going to see if people are making the best decisions possible. So some of the things we can assess, right? And we could assess that. We could do surveys, we could do, interviews of patients, but we could verify if, if they had access to a lot of different treatment options. Were they given information? Were they given like enough information to make the best decision? Are they satisfied about how they made the decision? So there's a lot of outcomes that are like decision-making outcomes, right? And so we've worked with the OMERACT group, Outcome Measures in Rheumatology. So I'm one of the chairs of the shared decision-making group. And so we're looking at what are the outcomes that we should assess to see if patients are really truly making the best decisions possible, right? So are they making decisions that are informed? Did they have enough information? Are they making decisions that match with their own values and preferences? Are they satisfied with the way they made the decisions? Or the adherent, like, do they follow the treatment that they chose? Or do they realize after the fact, like, oh no, I made a terrible decision and it's not what I wanted. And so there's different like outcomes that we can assess. So we could assess that. I think also for health equity, that's another even bigger conversation of what, I think for all people, depending on the characteristic, they should all make the best decisions possible. And I think that's tricky because a lot of people now are not making the best decisions, right? If you look at the studies now, a lot of studies will do interviews and they'll look at how people made decisions for their care. And often, they say they lack information, they lack evidence-based information, they're unsure what to choose. Or sometimes they choose treatments, but they're like, oh, it didn't really match my values, preferences. So then I stopped and I was unsure. So all these elements are not optimal decision-making outcomes.
And on the part of the clinicians, is there going to be a way or means where they're going to be able to assess their practice, their clinical practice, for instance? So not just through a patient lens, but through a clinician lens as well.
So I think clinicians have to always be open to give some of the power to patients, right? And I think that's one of the things that's a bit difficult sometimes, right? So if I'm a clinician and I tell people what to do, it's way easier because I can control everything. I can say, well, everybody who will come to me with these characteristics, they will get this medication or they will have this, or, And so I think there's a lot of questioning, I think, of, clinicians, are they ready to share like the power? And what if they give options to their patients and their patients said, I don't want this treatment, I want something else, so I think the patients anyway have the choice, right? They can decide whether they want medication or not. They could just decide to abandon everything if they want, right? But I think, so I'm not sure if I answered the question, but I think there's a lot of clinicians I've met through CRA, through OMERACT, who are clinicians who say, I will give all the options all the options that are relevant, that are available, and I will help my patients to make the best decision possible using kind of decision coaching. And, patients may choose something that is not exactly what they feel they would take personally, but that's okay because the patient is on a journey and they'll, and then they look at, their outcomes. Are they doing well or not? So I think like you can't really control the person's behavior in terms of, are they taking, the medication? Are they doing this or that? But the reality is giving them the choice will help. I think it will help them to achieve what they want quicker. Like now we have a lot of patients who also monitor their outcomes, right? Like you're taking this medication and you're looking at how does it work for me? And you're monitoring how you're doing. And then maybe you stop the medication when you think you have a side effect or you're not sure. You stop it and then you see, oh, is it getting worse now? So I'm not sure if clinicians are, okay with that. But I know as a patient myself also, like, to me, it's kind of, I like having the control to say, okay, I'm going to take this medication. I see how it's going and I can really monitor myself. And then when I see the physician next time in a few months, then I realize like, oh, maybe I lost a bit of time there, that I wasn't on the medication that worked perfectly, but I know exactly where I am now. I can just, so I think it's very, so I think they need to share the power and for health equity as well, right? Because people who are less educated but it's important that they feel that they're making the best decision for themselves.
I thank you for that answer. And I think I really am encouraged by the work and the leadership that you're showing. I think one of the things when we attend the CRA meeting, we're obviously meeting the new generation of leaders like you who are pioneering research and developing new ways to look at old problems that we have. And I think what's exciting for ACE and for our audience is to know that your leadership at a conference like it's going to occur in Winnipeg, you're going to be meeting and talking to the next generation of leaders. And I think they're going to be very open to this way of thinking, to this way of approaching a complex problem that is evolving, but it's only going to happen with that partnership between the patient and their team. So I think I'm very encouraged by what I hear you say, and looking forward to your presentation as well. So
thank you. I think we'll give some examples of how we can facilitate shared decision making, and I think we have some amazing experts on our team, and I think it's great to see we have patient partners. So I'm a patient, and I'm also a researcher and an OT by training, and we have also rheumatologists, pediatric and adult rheumatologists. So I think you need an interprofessional team. You need everybody together.
Absolutely. Well, thank you very much for your time today. And thank you to our audience for joining us today. Please join us again on another episode of CR Arthritis.